Hello friends, I am Dr. Deepak Garg. I am consultant orthopedic surgeon and today we will discuss about the implant selection before pre-operative planning in a revision total knee replacement surgery. So we have to look at the condylar reconstruction. For that we may need augments. For metaphyseal reconstruction we may need cones and sleeves, and stem we can choose a cemented or a uncemented press fit stem, and insert is a normal PS insert or valgus varus constraint insert, or sometimes we may use a hinge knee. So let's look at detail about all these things. So for the condylar or metaphyseal reconstruction, we may have to use the augments, cones and the sleeves. So this picture we can see this is a augment. So the augments or blocks are they replace the peripheral or marginal bone loss and restore the joint line. Similarly, these ring like structures or half rings, these are the cones. So we use it in the inner deeper metaphysis, where they fill the central metaphyseal defect, and they also lead to the ingrowth of the bone because of this porous coating. Then what are the sleeves? When the bone defect is very large, we are not able to contain the defect, then we use a sleeve. It fill the defect of the upper part of the metaphysis also, and it has a contact with the main condylar component also. So these are the augments, cones and sleeves. Now the stems are of three types. One is a cemented, other is uncemented and hybrid. So cemented are fully cemented in the canal, uncemented are the press fit, no cement is used, and hybrid where the cement is used only in the component and condylar component, and stem is press fit. So most commonly we use a hybrid stem because that will give the immediate stability for the patient to walk, along with the press fit of the stem that will give long term stability. So polyethylene again are multiple types of polyethylene are there. Normally we can use a PS normal knee that we use in a normal knee that is posteriorly stabilized. Then we have valgus varus constraints if there is a ligament laxity. Then rotating hinge platform, where if there is no ligament then we have to use rotating hinge. And CR is usually we do not use in revision knees. Then let's look at the classification for the bone loss, which is the basis for the use of our implants. So AORI classification, there are four types: 1, 2A, 2B and 3. So the type 1 in femur is called F1, type 2 in type 1 in tibia is called T1. So like in type 1 is there is a minimal bone loss in the metaphysis. So in this we do not have to use anything, we can just fill this defect and can use normal knee implants. Type 2A, there is a defect on one side of the metaphysis. So if the defect is more than 5 mm, we definitely should think about using augments, either the blocks or the wedges. Then AORI type 2B, there is a defect on both the sides of the condyle, both in the femur and either in the femur or on the tibia. So there is a defect in both the condyles, then that means we will may have to think about the augments for the condylar and metaphyseal reconstruction. And for metaphyseal reconstruction we may have to use cones here, and we may have to use a longer stem here. For insert, depending upon the ligament laxity, there are higher chances that we may have to use a constraint insert here, like valgus varus constraint insert. Similarly in F3 or T3 AORI type 3, here definitely we will have to use a longer stem. For condylar component we may have to use a sleeve or cones here. There is a higher chance that we may need a sleeve. And for insert here there is a higher chance that we will use a constraint valgus varus constraint insert, or we may have to use a hinge component or the hinge implant here. So this is how according to the bone loss we select the component. Like in type 1 we may have to use augment. In type 2A, augments plus wedges or sleeves. In type 2B or 3, there are higher chances that we may have to use valgus varus constraints or hinge insert, and cones or sleeves may be used. Then according to the bone defect, if the defect is less than 5 mm, we can fill it with the cement and screws, or if it is 5 to 15 mm, then we should think about the metal augments. Large metaphyseal defects, we may use cones, and there is a complete loss of the condyle, then definitely sleeves with large longer stems. Then according to the ligament condition, if the ligament is lax, then we will first try to balance the soft tissue. If we are able to balance properly, then we can use a posteriorly stabilized component. But if even after doing the soft tissue balancing, we feel that there is a laxity, we are not able to balance it properly, then we will think of valgus varus constraint. If we feel that we are not able to balance it properly, there is an absence of either of the ligament, then we should prefer using a rotating hinge platform. Now about the stem extension, there are two main types of the stem we already know, cemented or uncemented. If we are doing uncemented, then we should prefer a length of more than 75 mm, because that will have a cortical contact and will give more stability. About the tibial insert, we can use a PS if in routine revisions, or if there is a collateral laxity, then we can use a valgus varus constraints. Usually the thickness of the polyethylene is more than 10 mm, that we usually use in revisions. So this was all about the implants that we use in revision total knee arthroplasty. If you want me to make more videos, anything on revisions knee, please let me know about the topic. We can come with a new video. Thank you for watching this video. For more such videos, please like, share and subscribe to our channel. Thank you.